Good morning, everyone. My name is Michael Avillion. I'm one of the senior neurotology fellows at House Clinic, and I am actually in the military. So I'll be going on for my military career after fellowship. And so I picked a pertinent talk for this. I hope you all enjoy it. So today we'd be talking on noise-induced hearing loss, current understanding, and management. I have no disclosures. So exposure to noise is the most common preventable cause of hearing loss. 12% of the global population is at risk, and the WHO estimates that 1/3 of all cases of hearing loss are attributed to noise exposure. The rate of hearing loss among workers is 7% in the US. That increases to 23% in those with noise exposure. To the right is a graph from the CDC highlighting the prevalence of hearing loss in various noise-exposed industries, demonstrating that certain industries like agriculture and transportation, the dark red line and then the light blue line, have decreased, but many others have remained the same over a period from 1981 to 2010. As far as definitions of noise, there's various definitions. We categorize noise into two main categories: impulse and continuous. Impulse noises are singular sounds that can be intermittent, like gunfire, jackhammer. Continuous noise can be fluctuating, such as working in an engine room or on an airstrip. The amount of noise is measured by a sound level meter in decibel units, commonly referred to as sound pressure level. The decibel is a log 10 scale, so with each increase in 10 decibels, this sound pressure level or sound intensity increases by a factor of 10, as you can see in the blue graph below. So when we reference a normal conversation at 60 decibels, as you can see in the graph to the right, the figure to the right, we compare that to a vacuum cleaner at 80 decibels. That is a difference of 20 decibels, but actually it is 100 times louder. You can see then how something like a chainsaw or a hammer drill reaching sound intensities of 100, reaching sound intensities 10,000 times greater than normal speech. And you can see how that would cause hearing loss. For this reason, the OSHA, the Occupational Safety and Health Administration, and NIOSH, National Institute for Occupational Safety and Health, have created rules for safe noise exposure and need for hearing protection. OSHA creates and enforces regulations, and NIOSH focuses attention on pushing the scientific field of occupational safety forward. And we are familiar with the allowable limits for noise exposure, as you can see on the table to the right. And you can see the time of allowable halves with incremental increases in the decibels and the sound pressure level. Reversible loss, typically referred to as temporary threshold shift, results from exposures to moderately intense sounds, such as might be encountered at a live music event or by noisy power tools. And it can occur over days to weeks, but typically is within days. The damage occurs in the supporting cells and tip links without loss of hair cells. There is even some ability of stereocilia to rebuild themselves. And this is as evidenced by the studies in Norman et al., as well as Clark et al. And Gao et al. An example of a temporary threshold shift is shown in the 2017 study out of China, as you can see in the figure to the right. Over 26 healthy young adults underwent 3 Tesla MRI for 60 minutes. They all wore earplugs and had ears covered by sponge mats. An ABR was performed 24 hours prior to, then 20 minutes after, and then 25 days after MRI. As you can see in the bottom graph to the right, there was an average 5 decibel increase in the threshold after MRI that returned to normal. The peak sound pressure level during the MRI was 103 to 111 decibels during the imaging. Their conclusion was that better hearing protection is needed during a 3 Tesla MRI. However, temporary threshold shift may not be as benign as we'd like to think. Thanks to extensive research by Lieberman and Kujawa, along with others, an entity called synaptopathy has been linked both to noise-induced hearing loss and aging. The running hypothesis is that glutamate, the primary neurotransmitter from the inner hair cell to the cochlear nerve, is overproduced with intense acoustic stimuli, leading to excitotoxicity that damage the afferent nerve synaptic terminal at the inner hair cell, leading to degeneration of the afferent nerve fiber, eventually leading to delayed loss of spiral ganglion cells, despite preservation of inner hair cells, which allow there to be normal pure tones. The figure to the right demonstrates immunostaining of synaptic terminal markers, green and red, and shows the decrease after 100 decibels sound pressure level noise exposure for 2 hours. The light micrographs demonstrate degeneration of the spiral ganglion cells at 2 years post-exposure, and as you can see in figure D. This can be shown by an abnormal wave 1 waveform in controlled animal experiments, but in humans this is yet to be reliable, as there are uncontrolled additional factors that affect the ABR, such as loss of hair cells, prior hear loss, etc. Right. This is the current theory for poor speech and noise, as the auditory nerve fibers that degenerate primarily affect temporal processing. Additionally, the loss of afferent neural connection likely leads to increase in central gain, leading to hyperacusis and tinnitus, and further research is ongoing. When there is no recovery of thresholds, this is considered a permanent threshold shift, which involves focal loss of hair cells, starting with the outer hair cells and then progressing to inner hair cells. Frequencies around 4 kilohertz are most affected due to the resonant frequency of the outer ear and ear canal. The figure to the top right is that of a 50-year-old male with extensive occupational noise exposure, with a staining of organ of Corti in dark, showing an abrupt degeneration in the basal turn. As noise exposure, duration, or intensity increases, more frequencies are involved. The figure to the far right, bottom right, is the autogram of press operators over time in their occupation, from 1 year in yellow to 30 plus years in blue with the blue triangles. The green shaded region is the average hearing of age-matched controls. The mechanisms by which permanent damage occurs is divided into mechanical destruction and metabolic decompensation. Mechanical destruction is acquired by exposure to noise intensities of 90 to 130 decibels sound pressure level, leading to disassociation of the organ of Corti from the basilar membrane, as shown in the figure to the right, which is a chinchilla cochlea after exposure to 160 decibels sound pressure level, with the asterisk denoting the outer hair cells and their supporting cells, as well as the disruption of cell junctions and mixing of endolymph and perilymph. Metabolic decompensation results from glutamate excitotoxicity, as previously discussed, and reactive oxygen species, as shown in the figure to the right from Yamashita et al. This shows inner hair cell staining of 4-HNE in hair cells, which is a reactive oxygen species, and guinea pig organ of Corti, comparing the control to day 7 after exposure to 120 decibels sound pressure level for 5 hours. The highlighted white staining demonstrates immunoreactivity and corresponds with a peak of the reactive oxygen species at 7 to 10 days following exposure. This was then followed by extensive loss of outer hair cells in the noise-sensitive region that continued up to 30 days. As well, there you can see cellular swelling and rupture, as well as stereocilia disruption, along with ischemia from vasospasm and metabolic decompensation. Not all animals or humans respond the same to noise exposure, however. and research is unveiling that genetic susceptibility is a factor at play. Certain strains of mice, as well as knockouts, are more susceptible to noise exposure than their wild-type counterparts. The figure to the right demonstrates 4 clusters of mice and found that the most affected after noise exposure, which is cluster 1, the circles with the solid line, were homozygous for a gene AHL found in C57BL6J mice. Konins et al. Compared audiometric data and DNA samples from the 10% most susceptible and 10% most resistant Swedish and Polish noise-exposed workers. And significant interactions were observed between noise exposure levels and several single nucleotide polymorphisms of the catalase gene in both populations. And these findings indicate that catalase, a gene involved in oxidative stress, is potentially a noise susceptibility gene. This same group found that heat shock protein, which assists in protein functions and increase in expression under noise exposure, single nucleotide polymorphisms were associated with noise-induced hearing loss in 3 independent populations. Now that we have a fundamental understanding of noise-induced hearing loss, we will transition to the clinically relevant current therapies for acoustic trauma, as we all have and will encounter patients who have recently had threshold shifts from acute noise exposure. Steroids have had a therapeutic beneficial effect on noise-induced hearing loss when given before or after acoustic trauma in animals. The figure to the top right is the ABR thresholds in mice 7 days after exposure to 110 decibel white noise for 60 minutes. As you can see, the untreated noise-exposed mice in the squares with the solid line had significantly worse ABR thresholds compared to the steroid group in control. Additionally, post-mortem evaluation found that the organ of Corti and efferent terminal outer hair cell synapses were less damaged than the steroid-treated groups in this study. There were actually 2 steroid groups, intraperitoneal, IP, and intratympanic dexamethasone, IT. Interestingly, organ of Corti architecture was better preserved in the systemic or intraperitoneal group, and the efferent terminal outer hair cell synapses were more intact in the IT group. Upon systemic administration, the agent is thought to have spread through the stria vascularis and then diffuse into the scaled media, exerting direct effects on the organ of Corti. In contrast, upon intratympanic injection, the steroid can enter the scala tympani first, reaching the organ of Corti more slowly. The mechanism of protection of steroids in acoustic trauma is still unclear, however. Inner ear glucocorticoids and mineralocorticoid receptors have been discovered. The exact role they play is yet to be elucidated. However, current understanding is that steroids exert protective effects through stabilization of cellular membranes and preventing cellular edema, scavenging of free radicals, and inhibition of lipid peroxidation, and preventing or lessening fluid and ionic imbalance. In humans, the studies on steroids and acoustic trauma with control groups come mainly from military exposure, with the exception being the Boston Marathon bombing. 2 studies out of Israel in 2016 and 2022 found that early treatment within 10 days of soldiers with systemic steroids after acute acoustic trauma had improved thresholds compared to controls. As you can see in the figure to the right from the study, Zlock-Zauer et al., with an average threshold gain of around 7 decibels in the final audiogram. The highest improvement was when the steroids were initiated within 24 hours, and the high dose was continued for 7 days. However, Raymond Schneider et al. in 2014 investigated the otologic outcomes after the Boston Marathon bombings and found no statistically significant changes in the bone conduction thresholds between patients who received steroid treatment, a total of 8 patients, in the immediate post-blast period, and those who were not treated with steroids, although they did notice a, quote, clinical trend towards improvement, end quote. The graph to the right shows, demonstrates their results with the white circles being pre-treatment and the closed circles being post-treatment. Studies evaluating the combined trans-tympanic and systemic steroids have found more beneficial effect than monotherapy. Zhao et al. Evaluated 53 patients post-exposure. The TR group, seen on the right, included systemic methylprednisolone for 10 days, along with 4 doses of IT or intratympanic methylprednisolone, whereas the control group had systemic methylprednisolone without intratympanic steroids. Significantly more patients in the combination group had improvement in the pure tone average, greater than 15 or greater than equal to 15 decibels. And for this, the percentage was 52% compared to 23%. And in speech discrimination, greater than equal to 15%. And the treated group was 67% compared to 31% at the 8-week audiogram. Chang et al. In 2017 evaluated 19 patients exposed to gunshot fire, comparing prednisolone only for 10 days to prednisolone plus 4 treatments of intratympanic dexamethasone. There were no differences in baseline characteristics, and treatment is initiated 6 to 7 days post-exposure. Baseline and 1-month audiogram were performed. The table at the bottom shows the results, and as can be seen, the final audiometric thresholds in the green box, the final audiometric thresholds were significantly better in the combination group, which is the green box, compared to the monotherapy, which is in the red box. Now we will discuss hyperbaric oxygen therapy. A study of guinea pigs by Lam et al. Found that with sequentially higher noise exposure levels, there was a reduction in the partial pressure of perilymphatic oxygen, as well as cochlear blood flow. Lukowski et al. In Finland retrospectively investigated hyperbaric oxygen therapy versus normobaric oxygen therapy in young military conscripts after acoustic trauma from rifle fire. They compared 60 ears treated with hyperbaric oxygen therapy with 60 ears treated with normobaric oxygen therapy. The hyperbaric oxygen therapy was given daily on average for 6 days. And the average recovery of hearing both at high and speech frequencies was significantly better after the hyperbaric oxygen therapy than after the normobaric oxygen therapy, as shown in the table to the right, with around 70 to 75% of recovery in the initial hearing loss for the hyperbaric oxygen therapy group, compared to 55 to 60% for the normobaric oxygen therapy group. And you can see the hyperbaric oxygen therapy group is in the green box. Normal hearing at the end of the follow-up period was regained in 70% of ears in the hyperbaric oxygen therapy group, and in 40% of ears in the normobaric oxygen therapy group. Notably, there was also less of a persistence of tinnitus in the hyperbaric oxygen therapy group. Three different studies comparing hyperbaric oxygen therapy plus steroids to hyperbaric oxygen therapy alone found a significant improvement in the combination groups. To the right, we see the results of Bayumi et al. Study in the Netherlands, which retrospectively compared hearing improvement between 2 groups of Dutch military soldiers with acoustic trauma and threshold shifts. Both groups were treated with high-dose prednisone for 7 days. but the treatment group had the addition of 10 sessions of hyperbaric oxygen therapy. The post-treatment percent of recovery was significantly different at 4 kilohertz, which is 53% compared to 31% recovery, and at 6 kilohertz, which was 59% compared to 28% in the control group. Holy et al. In the Czech Republic found a significant improvement at 5 kilohertz and 2 kilohertz. And Oya et al. In Japan treated patients from the Japanese military with hyperbaric oxygen therapy after being referred for after acoustic trauma. 30 out of 37 of those patients had been treated with steroids prior to evaluation. And of those treated only with steroids, only 23% had improvement. After hyperbaric oxygen therapy, 77% had improvement. And this was even when hyperbaric oxygen therapy was performed on average 26 days after treatment. In a 2020 meta-analysis by Ahmed et al., published in Military Medicine, they found that a pooled analysis of 6 studies, which is 283 patients, found on average a 12 decibel improvement post-treatment in the high frequency pure tone average, as shown in the figure at the bottom, as well as a 7 decibel improvement in the pure tone average with combination hyperbaric oxygen therapy and steroids. Steroid therapy alone improved the high frequency pure tone average by 9 decibels and pure tone average by 6 decibels, but there was insufficient data to compare these 2 interventions against one another. However, a few studies, such as that of Van Heesendok et al. In 2018, which evaluated 43 patients after the Brussels suicide bombing in 2016, found no difference in steroid versus combo steroid and hyperbaric oxygen therapy. Though in this study, a much larger portion of patients in the hyperbaric oxygen therapy group had sensory neural loss. There are a variety of studies indicating the best time for treatment, but clearly the consensus is earlier is better. This is, as we discussed, due to the numerous metabolic factors at play. And these metabolic factors continue to escalate for 7 to 10 days after acoustic injury. Bayumi et al. In the Netherlands, referenced in the prior slide, performed a more recent study in 2021, comparing if earlier treatment of acoustic trauma with combination of therapy affected outcomes. The results shown in the right have demonstrated that the absolute and relative hearing gain after treatment are significantly better when therapy is initiated within 2 days, demonstrated by the green box, than when initiated after 2 days. This was also confirmed by a meta-analysis by Kachukzadeh et al. In 2020. This is an ideal timeline, but often not feasible in the clinical setting. Oya et al., as previously discussed, found improvement up to 4 weeks out from acoustic trauma with hyperbaric oxygen therapy, although there was no control group. The vast majority of studies, which we don't have time to go through, initiated treatment within 2 weeks, and all are within 1 month, and still the consensus shows benefit. Although again, these are retrospective studies with few control groups, and there's no purposeful delay of treatment, as that would be typically unethical in order to follow a study design. As you can tell, the vast majority of studies have evaluated steroids and hyperbaric oxygen therapy in acoustic trauma, but there are a few other therapies to discuss, such as the role of antioxidants. As we discussed, the generation of reactive oxygen species is part of a metabolic mechanism of hearing loss. And this can lead to ischemia, excitotoxicity, and ionic imbalance in the inner ear. These reactive oxygen species have been found in the cochlea of animals, but also in the serum of occupational workers exposed to loud noise. Kayguses in Turkey et al. In Turkey performed blood draws on industrial workers exposed to various levels of noise during an 8-hour workday without hearing protection and compared this to a control group. They found that those with noise-induced hearing loss and those with the loudest occupation had significantly higher levels of glutathione peroxidase, a free radical scavenger, as well as higher levels of MDA, an indicator of lipid peroxidation. N-acetylcysteine is a well-known and safe and well-tolerated drug used in a clinical setting, such as in reactive oxygen species-induced liver damage due to Tylenol overdose. It has been documented to act as a free radical scavenger and substrate for glutathione production, mitochondrial protectant, a glutamate excitotoxicity inhibitor, a lipid peroxidation inhibitor, and necrosis inhibitor. In a study by Fatoni et al. In Italy in 2009, guinea pigs were exposed to 120 decibels for 30 minutes. One group was treated with intraperitoneal NAC, while the other was a control with saline injection. The treatment was initiated immediately after exposure, and then every 24 hours for 2 days. Round window compound action potentials were recorded as shown in the figure to the right. And there was a significantly greater threshold shift in the control group at 7 days post-exposure compared to the treatment group. There were also a significant difference in hair cell counts in the basal turn, as 43% of cells were counted in the basal turn of control animals compared to 80% counted in animals treated with NAC. While numerous animal studies have been performed, those in humans are more limited. Induced et al. In Iran evaluated temporary threshold shifts in 48 textile workers and showed that daily oral administration of NAC 1,200 milligrams per day during continuous noise exposure prevented the occurrence of threshold shift after 14 days of treatment. Whereas the untreated group showed a temporary threshold shift of approximately 1.5 to 3 decibels, as shown in the table to the right, top right. Lin et al. In Taiwan also found a significant improvement in high frequency threshold shift after NAC, which was 1,200 milligrams per day for 14 days. However, the mean difference in temporary threshold shift and placebo-treated group versus NAC-treated group was only 0.3 decibels, as you can see in the figure to the right. Kopke et al. At the Naval Medical Center of San Diego performed a randomized double-blind placebo-controlled trial among a large military group of 566 patients with a total daily dose of 2,700 milligrams of NAC for 16 days during weapon training, and found a non-significant reduction in hearing threshold shift rate, as shown in the figure to the right. But this was statistically significant when handedness was taken into account, i.e. evaluating the effect of the right ear only in right-handed participants. As far as post-acute treatment, Rosenhall et al. In Sweden in 2018 performed a retrospective study on 221 Swedish Armed Forces personnel exposed to acoustic trauma, mainly from weapons. 400 milligrams of NAC was given immediately after the acoustic trauma, then 800 milligrams was given 24 hours later in the treated group. The prevalence of post-exposure of high-frequency hearing thresholds greater than 25 decibel hearing loss, and the incidence of transient threshold shifts greater than 10 decibels, shown in the graph to the right, was lower than the NAC group than the non-NAC group directly after the noise exposure. However, at final audiogram around 9 months, there was only a difference of 4 kilohertz for the right ear. Otherwise, the thresholds were similar for both groups. Given that temporary threshold shift is a precursor to permanent threshold shift, a role of NAC is promising, but larger randomized studies are needed. Other antioxidants that can potentially play a protective role against noise-induced cochlear trauma include ginseng, coenzyme Q10, as well as several vitamins such as vitamin A, vitamin C, vitamin E, and vitamin B12. Laprelle et al. At Ann Arbor, Michigan in 2007 showed a protective benefit from combination antioxidant treatment with magnesium and vitamin A, C, and E, possibly due to synergistic effects. The graph to the right shows ABR threshold differences prior to and 10 days post noise, which was 120 decibels sound pressure level for 5 hours. In guinea pigs treated with saline, vitamins A, C, E, magnesium, or vitamin A, C, E, and magnesium, demonstrating a significant reduction in the combination antioxidant treatment, which is the bar farthest to the right in this table. Of course, these studies of the aforementioned antioxidants are mainly performed in animals or in small groups of humans, and the results should be considered preliminary. Beyond a doubt, prevention remains the best option for eliminating the effects of acoustic trauma. A recent Cochrane review concluded that in order to prevent occupational hearing loss, better implementation of legislation and better prevention programs are necessary. This is not universally adopted, though, as one-third of countries in the world still do not have regulations or legislation regarding permissible noise levels. In that case, hearing protection offers a secondary level of protection. However, compliance remains a real issue. In an interesting study by Avillion et al. In Portugal, the group evaluated workers through questionnaire and their compliance with 4 different types of hearing protection devices, as shown in table 2 to the right. They used an equation to calculate the effective daily exposure of the workplace environment, far right figure, based on the time use of hearing protection devices, and found that devices with lower attenuation but higher comfort were more efficient than protection with higher attenuation devices but lower comfort due to compliance issues, as can be shown by the column titled RA for relative attenuation, where higher numbers indicate higher attenuation, and therefore actually reduce the effective daily exposure level in 4 different workplace environments. Individual fitting is therefore very beneficial. Studies have found that custom earplugs have a more consistent attenuation than non-custom earplugs. Additionally, fit testing, which measures the effectiveness of hearing protection devices specifically for each individual, can be invaluable, particularly when earplugs, since they are generally less consistent in noise reduction than earmuffs. In conclusion, noise-induced hearing loss is widely prevalent and preventable. Earlier treatment is more effective, with the current data most heavily weighted for steroids, hyperbaric oxygen therapies, and possibly N-acetylcysteine. Synaptopathy has increased evidence for detriment in speech perception and noise and downstream deterioration in hearing. Primary prevention of noise-induced hearing loss through legislation, education, and hearing protection is what will make the biggest impact. Future studies are needed to elucidate the effectiveness of pharmaceutical options to prevent or mitigate noise-induced trauma. Thank you for your time.